Hello, everyone. Welcome to this new installment of the SEED series of No Diabetes. I think this is the sixth installment, and we had some feedback from our audience. They want us to try to go back to basics a little bit more. So, talking about basics and diabetes, we could not think of a more suitable person when it comes to diabetes education than our normal host, Anne Norris. So it does give me great pleasure to actually bring on Anne, and we're going to have a chat about diabetes, some of the basic facts and some of the basic knowledge that people need to have with diabetes. Welcome, Anne.
Thank you, George. It's nice to be in the other side of the seat.
Yes, I know. I'm always easier to be on the other side as well. But look, as I said earlier, we have had some good feedback from our audience, and they do want to go back to basics. So we just thought it would be a good idea, perhaps start with, what is diabetes and the different types of diabetes, and the triggers for diabetes and symptoms. It's a huge topic, but maybe I'll leave it up to you to try to simplify it as much as you can.
It is a huge topic, and I think certainly we know so much more these days, don't we, about what the trigger points are, but also about the variants of diabetes. It used to be very straightforward once, where you had juvenile onset or type 1, then you had maturity onset or type 2, and now diabetes is quite complex across the whole continuum. And not everybody gets type 1 when they're a child. We have adults who get type 1, and we have the elderly who get type 1, as well as people who get type 2 are also young, as well as middle-aged and elderly. So there's no classic scenario these days. And there are many causes and triggers to the onset. It's not always straightforward to diagnose, but there are 4 main types of diabetes in the classification. Impaired glucose tolerance and impaired fasting glycemia we also use is often referred to as pre-diabetes, and we'll talk a little bit more about that. But basically, it's pre-diabetes often. Then we have type 1 diabetes, and the variant of that is now called autoimmune diabetes in adults. It's a recent new classification for type 1 diabetes. And then we have type 2 diabetes, of course, and then we have gestational diabetes. Impaired glucose tolerance is not diabetes. And next, thank you. It's not diabetes, and it's really important that we don't say that people with impaired glucose tolerance are borderline, and it's very important that we don't give them a diagnosis that they don't have. So it's not diabetes, but it is impaired glucose tolerance, and it could either mean that you've got an impaired insulin secretion, or you're not able to actually metabolize glucose properly for a variety of reasons, which are quite complex. It's a fasting of 5.5 to 6.9, and you might have a test called the glucose tolerance test, where you drink 75 grams of glucose and then they take blood before that, and at 1 hour and 2 hour intervals. And if the 2 hour interval for that is between 7.8 and 11, then you have what we refer to as impaired glucose tolerance. People with this condition also may have high blood pressure, and that needs active management, and people may have cholesterol issues, and that also needs active management to lower the cardiovascular risk factors. And these are all 3 are very important things to co-manage, equally as important as the other. We also need to do something really important with this, and that is monitor for type 2 transition. And if people have had an HbA1c of 6.5 or greater, we know that that's occurred. It's silent, so people don't feel it. What are the possible triggers to the onset of diabetes? And we'll move through this a little bit more quickly, so we can get to the other part of this. But the general triggers that are associated with the onset of both impaired glucose tolerance and then diabetes, particularly type 2 in this instance, can be weight gain, sedentary lifestyle, where you don't do a lot of exercise and you sit in an office all day, a physical illness or a major physical stress, and it could be something like a stroke or a heart attack, for instance. A stress can be emotional or physical stress. These are physical stresses. but these emotional stress can be also a trigger. There are some people who develop a medication-induced impaired glucose tolerance or diabetes, and that's generally in the presence of medications called steroids, and they certainly block insulin action, therefore raise the glucose levels. If a woman's had a history of gestational diabetes, that can certainly be a high risk factor for the onset of type 2 in a few years down the track. And we also know from a study that was started in the 90s and was first published in 1998, and for those of you who want to know what this is, it's called the UKPDS. It was referred to as the United Kingdom Prospective Diabetes Study, and I think it's still actually going. George might correct me here, but it's looked at a whole lot of outcome data with type 2 diabetes, and they marked that blood pressure was a marker potentially for the increased risk of the development of diabetes.
Yeah. And can you, would you mind expanding a little bit about diagnosing and when it comes to type 1 diabetes and how it is normally the most commonest way of diagnosing type 1 diabetes, through hypoglycemia and admission to hospital for kids?
Yeah, type 1 diabetes is certainly, it's certainly most commonly diagnosed in children and young adults, and it often presents very acutely because people often think that if they keep checking their glucose when there's a history of type 1 in the family, that they'll pick it up early. But in fact, that's not the case. And I do have a slide that shows that there is this progression, and I'll come to that in a moment. But there is a slide after next, I think, where it shows that there is up to a 5-year progression towards the onset of diabetes from a triggering event, we call it, and that over time there is a loss of insulin secreting cells that eventually, when only about 10% are there, then that's when the type 1 diabetes is diagnosed. And this means that there is just insufficient beta cell population available to produce enough insulin. And of course, we know that insulin is an essential hormone for normal life expectancy.
And I know this is a bit of a controversial topic, but triggering event, can you give us some ideas of what could be a triggering event?
Well, there's a lot of ideas about this, and I think if you ask someone like Professor Len Harrison, he'd have a wide variety of options. He's done an incredible amount of research with type 1, and he would have an enormous array of what he thinks the triggers are. Some people think there are environmental triggers associated with vaginal delivery, which is the optimal way to deliver a baby, so that they get exposed to it's 30 trillion bacteria, I think, in the process of a normal vaginal delivery, which stimulates our immune systems to protect us. And if he believes, I think, that one of the environmental triggers is a high rate of cesarean section. Now, I haven't really talked to him for a while about why he thinks that, but if you correlate the two and your immunity doesn't get prompted and triggered, then maybe that predisposes you and exposes your immunity to turn on itself.
So there's probably something to be said about not stopping our children from rolling in dirt.
Yes, absolutely. My word, there is. There's a lot to be said for not stopping our children doing that. Yeah. I also think that there is a common belief that is often been a viral trigger. And sometimes we really don't know the trigger, and we call that idiopathic. So there are all sorts of potential triggers to the actual start of that process. Essentially, though, we do know the importance of a genetic link, and we can now measure for that and to see whether or not people with a first-degree relative of someone with type 1 diabetes has actually inherited these specific genes that then will we were able to then go on and say, well, you have a higher prevalence in terms of getting type 1, or you have a lower prevalence and I think a lower risk. And I do think that there's incredible work being done in order to try and identify further those genetic links that can predispose risk.
And of course, I think genetic profiling is always it's not 100%, but it gives you a very good idea
Yeah.
of the risk present, doesn't it?
That's exactly right. And I do think when we're talking about type 1, the onset of these symptoms is incredibly fast. So when you think about that curve of how long it takes to develop type 1, if you're checking your glucose to look for it, you can have what is actually a glucose level that is not in the diabetes range, and it can be what we call euglycemic and not indicate any diabetes at all. And then a few weeks later, you can have full-blown diabetes.
Right.
Type 1. And so in type 2, it's a little bit different because it's more insidious. But with type 1, it's an acute presentation most generally, and the person is often quite sick by the time they get diagnosed.
Right. Will you be going back to that slide you had, the slide previously about the progression from the type 1, the one with the graph? That one there, yeah.
So when you look at that, it's a quite, and this can occur from over months to some years. Some people say that those years can be up to 5 years from that triggering event to when overt frank diabetes occurs. And way back when I used to work at the Children's, I remember we would often know of a major viral event like the child had developed measles or German measles, or one of those common in those days common childhood illnesses, or they might have had viral meningitis or some triggering event that was quite significant in terms of physical well-being, and this has started the process where because I think at one stage there was early viral early viruses shown in those beta cells where they'd been destroyed by our immune system, and they did at one stage find viral fragments in those beta cells. It's fascinating. So when you think about that, and you understand the process that leads to the onset of type 1, you can see that first of all it's not avoidable. It isn't anything to do with lifestyle. It's purely physiological, and that it has to be then generally managed in an admission, unless you're very lucky, where it's got to be stabilised carefully. And this always requires insulin injections. You can't take a tablet to treat this. And of course, healthy diet, regular exercise, and a normal part of managing type 1.
And I presume this is
that option.
Yeah, this is the differentiation between type 1 and type 2, where you do require insulin because your beta cells are gone.
Yeah, that's exactly right.
Yeah.
Exactly.
Right.
And the signs and symptoms of diabetes is pretty much the same, except that in type 1, you have a really sudden onset of excessive thirst, passing a lot of urine, and quite visible weight loss, which is happening rapidly without trying. And, young people can lose 10 kilos in a very short period of time. So the onset of symptoms is quite rapid and quite vicious. Whereas with type 2, it's much more subtle. And so you have other elements come into the diagnosis of signs and symptoms of type 2 diabetes, which can include lethargy and tiredness. Sometimes people have more recently gained weight, and you can have recurrent infections, and maybe there is some blurred vision associated with rising glucose levels as well as if the glucose levels are high enough, the thirst and the passing a lot of urine. But the two are similar, but you won't have some of the more entrenched symptoms that occur in type 1 because they just aren't going to be as ill for long enough.
Just to help some of our listeners, I mean, these are very generic symptoms and signs.
Yeah.
I mean, I'm always very thirsty after I play sport or something. But can you expand a little bit more, or like when you say passing lots of urine, are you talking about every 2 hours, 1 hour, 5 minutes, or 6 hours? On the average?
Yeah. It's a good question because, for instance, if you're talking about, let's split them up a bit. If you're talking about a child who's developing type 1, they may have already stopped wetting the bed, and yet they suddenly start to wet the bed and they become incontinent overnight. And that can be one of the early signs that you can look for that highlight the fact that there may be something else going on there. And that's certainly something I would say would be something to hone in on. But it may well be, yes, you're right. I mean, if you've been doing a lot of exercise and you're drinking a lot of water and you're burning, you're quite active, you will be thirsty. And so it's putting those things into context. But I mean, some people with type 1 diabetes have described their thirst as wanting to drink the tap dry. And this is probably a slightly more old-fashioned term that used to be stated way back. But I've known people more recently to say the same thing. I could just drink the tap dry because their thirst was so overwhelming. And I think they're more of those extreme responses that people can experience. As for going to the toilet a lot, of course, if you're drinking a lot, you will pass a lot more urine. But again, it is those things that you just find you're just completely, you really are. It is going through you all the time. And it's your body trying to normalise the glucose, of course. That's what's doing it, as well as you drinking a lot. And so you have to look beyond what might be the normal and the context of everything to say, no, this is not right. This is certainly not normal. And you don't feel right. And of course, if you're working hard, lethargy and tiredness can also be associated with that, can't it? But it's about really not feeling well on top of other things. It's more than just being tired after a long day.
Yeah,
it's really trying to associate what's happening with the rest of your body.
Which points to the importance of being alert and looking at what is happening, and then talk to your healthcare professional. Talk to someone. Don't take it for granted. And, I have had people coming to me and saying, "Of course he goes to the toilet. He drinks water every 5 minutes. So he's got to go to the toilet." But actually, there's always a little bit more behind the reason for that, for the cause, and the cause could be something like diabetes. So always talk to your healthcare professional.
Absolutely. I was going to say that. I mean, I do think these days we're in a very fortunate position. GPs particularly, who see their patients on a very regular basis, usually will be looking for it. They're alerted to check for a fasting glucose, because we do know that the earlier we also pick it up, the better off everyone is. So being proactive with their medicine is also helping to pick it up quickly, meaning that the signs and symptoms aren't always that obvious. It doesn't mean it's not there, because it's type 2 particularly, as we know, is a very silent onset in a lot of cases, isn't it?
So if you're talking about, I mean, a lot of, it could be of concern to some people when you say type 2 is silent. So they'll say, okay, how do I know? And by the time when I'm 40, 50, 60, how do I know? How can I start suspecting that I may have type 2 diabetes?
Well, I think if there's a family history, I think if you've been told that you've got a family history, or even if you don't, I think if you have some concerns and you like the doctor to check it out, don't hesitate to go and see your GP and say, look, I have a family history. I just wonder whether or not you'd like to check my glucose to see what it is. And a fasting glucose is going to set in place a whole lot of things. So they'll do cholesterol, they'll do a fasting glucose, and they may, if that comes back elevated, then they should send you for a glucose tolerance test. Will be definitive and help you identify, or him identify, or her, what's going on with your health. But it's a starting point. You need to, don't be frightened to do it, because your future health depends on you being proactive with your own care.
Yeah, and also I think recent developments also will allow them to even do a simple HbA1c test, and non-fasting can be done random, and you will give them a good idea whether you are at risk of diabetes. You talked about gestational diabetes. Can we talk a little bit more about that?
Gestational diabetes?
Yeah.
Gestational diabetes, it's a really important topic, and we don't talk about it very much because it's a niche area. But gestational diabetes occurs at about 26 to 28 weeks, and it's caused by the presence of a hormone called placental lactogen, and it blocks insulin action. Simply, it blocks insulin action. It impacts on its capacity. And because of the importance of diagnosing gestational diabetes, all women are checked using a glucose tolerance test at this time in their pregnancy. And the reason why this has occurred now is because we know about the number of women who became unwell in the pregnancy and the number of babies who were either born early or who had problems after, and who had problems after delivery because of that, but also who may not have actually survived the pregnancy, where the blood glucose levels of the mother were elevated and the baby either was delivered early and had respiratory problems as a result of that, or the baby was born early because it was large and it was born by cesarean section, meaning that it was a premature delivery. And if it was born normally, or either way actually, then in women who have not had good blood glucose control through the pregnancy and they haven't been within target, the baby will experience low blood glucose levels when it's exposed and it's got no more of the mother's access to the mother's nutrients. Yeah. So there are a whole host of reasons why this can occur from the baby's point of view and why we need to diagnose it. And there are also reasons to keep the mother well and to make sure that from both mother and baby points of view, we diagnose GDM. Women who develop GDM need to be monitored closely for the development of type 2. And some women get type 1 post-pregnancy as well. And we often believe that this is going to occur and possibly is going to occur within 5 years of diagnosis of GDM. So they say about 40% of women who get gestational diabetes may develop type 2 within 5 years. So there's an incredible impact on the type 2 diagnosis prevalence from women who develop gestational diabetes. And I haven't put it on the slide, but the criteria for diagnosing gestational diabetes is quite rigorous. And it's a fasting of 5, which is pretty hard to get to, and or a 2-hour post-glucose load of 8.5.
I think
the 1 hour result is also significant here. So it's really pushing it, and it's very hard to get a normal glucose tolerance.
I mean, it's a good indication of the WHO and the Australian pregnancy group. They decide to tighten those limits for exactly those reasons, as you said. You know, the risk to the mother, to the baby, and of course the possibility of developing type 2 in the future. How about should you talk to someone if you're thinking of going to become pregnant?
Oh yes. I think there's 2 answers to that question. Oh, there's probably more, but I'll go with 2. You know, if you've got diabetes, certainly, let's go with one first. If you've got diabetes, type 1 or type 2, it's imperative, even impaired glucose tolerance, it's imperative that really good consultation with a diabetes educator and your doctor is going to set you up to actually go into that pregnancy with full knowledge and understanding of what's required in terms of your monitoring of your own condition, but also how important it is to have really be at target with your glucose levels before you actually conceive, to make sure that the development of the baby is healthy. So from a person with diabetes point of view, it's absolutely critical to have pre-pregnancy planning and counselling around this. And for people who have type 1, if you're planning pregnancy, then you can access, even if you haven't got a healthcare card, you can access through the current availability through NDSS, you can access the CGM technologies to facilitate refining your glucose levels and to get you to target so that you're happy to conceive and your body's ready for it and everything goes in the right direction. And you can get that, there is a limit on it. So if you start by monitoring yourself, you should try and conceive and be ready to conceive 6 months into that so that you can continue to monitor through the duration of the pregnancy and just beyond. But there is a limit to, you can't just say, I'm going to get pregnant in 5 years and have CGM free for the rest of it. So there is a commitment to that. For type 2 people, they can't access the technology, which is a real shame, I think. Nevertheless, it's equally as important for those women to get pre-pregnancy counselling so that they are well when they become pregnant and they conceive, and then really close alignment with both an endocrinologist, the treating obstetric team and a diabetes educator to make sure that because even if you're not on insulin when you have type 2 diabetes, you will need insulin through the pregnancy.
I think that's
and it may well be that you don't even wait very long. You might need insulin quite early in the pregnancy to maintain good blood glucose levels.
That's an important sort of message, isn't it? That you will probably need insulin during your pregnancy. So it's quite a responsible way of going about managing your glucose levels during pregnancy, isn't it, with insulin?
Look, if there's a family history, there's a couple of things about it, isn't there? If you've got a family history and you get into the 26 to 28 week period and you get GDM, well, that is what it is. But you might find that you've got 4 pregnancies and you only get GDM for one of them. You won't necessarily get GDM for all 4, but then you might too. So there's quite a variable between pregnancies, isn't there, George?
Yeah, absolutely. All right. So you talked about technology. I mean, I think one underlying principle here is that glucose monitoring is a key requirement for all forms of diabetes. If you cannot manage your glucose levels, you'll be in trouble. And we can discuss later on about the long-term effects for that. But can you perhaps talk a little bit about the technology that it's available for type 1s and type 2s? There you go.
Well, unfortunately, there's great technology availability. Unfortunately, it's not accessible to everyone, which I think is quite a shame. I understand the constraints, but it has got so much benefit because using continuous glucose monitoring let's start there. Let's look at those systems that are available, many of whom are standalone systems. You've got flash glucose monitoring with Freestyle Libre, and then you've got Guardian and Dexcom systems that are also standalone as well as associated with pumps. And they really do, they've changed everything in regard to the visibility that people can now have to manage their diabetes, to get an aim for being maximum time in target rather than, good and bad glucose levels. We now talk about time in target, and we optimize that for as long as possible each day. And before we go into the pump scenario, these technologies are available for people with type 1 diabetes. Currently on the ESS, you have to have a concession, or you have to be planning pregnancy or be pregnant to actually access those, or be under 21. And so it is good, but it's also got a long way to go for all people who, basically, I think all people who are on insulin should be on it.
Right.
It is beneficial to the whole cluster, basically. Right. There's no to be exempt, except
I presume someone is not entitled to have a CGM. They can always have the blood glucose monitoring.
Yeah. Oh, yes, absolutely. Yeah. Yes, I'm moving into that. I think that for the free access, you have to be in that criteria that you pay for it then. And yes, of course, it is expensive, but the benefits are incredibly enormous. Right. And of course, you have really good blood glucose machines these days. They take a small drop of blood. They are 5-second tests. I remember when the first blood glucose machine came out in Australia, and it was done by Stan Clark. It went up on social media not long ago. You had to warm it up for 10 minutes, put it on the strip, wait for 1 minute, wash it off, blot it, put it in the machine, and you know about the other types of strips that were around then. I mean, they were amazing. We thought it was amazing. Now we've got this whole other, marvelous future with these technologies coming onto the scene and everything that goes with it.
But there is, so basically, can you summarize by saying there is technology out there to help us to do that? Some of it is supported by governments, some are not. So you need to...
Exactly right. And of course, then you've got the semi-automated systems, and they are developing rapidly, and what's ahead is going to be amazing because it's moving at a rapid pace in terms of what's going to be next.
I was going to ask you to make a comment about lupus.
So anyway, yes, there's a lot coming, and I think when we talk about closed loop systems and what that's going to mean to people with type 1 and trying to make it accessible to everyone. Because the research and the development of these technologies is incredible. When you go to the factories, it's amazing. You have to sort of takes a bit of getting your head around. So that they are coming. And of course, the other thing that frustrates people, I guess, in Australia is they see these things on social media, but we are a small population by comparison. So we don't always get first dibs at the first lot of technology releases. The bigger countries with the bigger populations do, often America. We are in the system, but we are in the loop for getting them, but we have to wait our turn, don't we?
Yeah. Absolutely. Yeah. All right. Well, we talked about how about the long-term management for diabetes?
Well, there's a lot in here. So I think the most important thing for people to take away with us is from us today, apart from all the other things we've said, is that diabetes is relentless. So making sure that that there is active management in terms of your psychological well-being, and making sure that you are engaged with a good support mechanism, that with a psychologist, for instance, who is going to be your backstop if you have problems with your diabetes. It's pretty relentless, and people can often feel very burnt out by the demand on their own self-care. Regular visits to the healthcare team is really important here. I realise I put active management twice, but and I didn't mean to do that. But I think that it's really about reinforcing the importance of talking to your team, getting settled with a team and sticking with that team. If you're getting on with the team working for you, don't move if you can help it. Maintain long-standing relationships, because they are like gold. And so if you're comfortable with your treating team, see them on a regular basis. And if you need to see them more regularly than at times than others, that's normal. There are times when people come back and they'll say, I need to see you every couple of weeks for a month. And then they're right, and then they go again. And this is really part of the normal cycle that diabetes and people with diabetes go through. So you see people on a regular basis, at least annually, and more frequently as the need arises.
Right.
People with diabetes need specialist care. You need to see an endocrinologist. Not every person needs to see one. General practitioners have got great skills and they are perfectly capable of managing people with diabetes. But some people with diabetes need expert care, they need specialist care, particularly when they're using different types of technology, because that's just where that fits. And you need a good credentialed diabetes educator to help you with all the technologies available, because there's a mountain of paperwork and a mountain of learning there's a lot of skills to learn around it in terms of adjustment to these technologies. So finding someone who you can relate to and who is accessible is really important. You need to have an annual eye review, and you often need a review of these, of your eyes and your feet at diagnosis with type 2, just to get a baseline. That's not uncommon. So don't think there's anything wrong if that's in fact part of your care plan, if that's what you do. Annual reviews with dietitian and podiatry are essential. And from a VicRoads point of view, you need to have there's mandatory reporting with VicRoads. So as part of that, there is a medical for people on insulin and people with type 1, 1 to 2 yearly, depending on the previous assessment. And if you've got type 2 diabetes in your own diet only or tablets, then it's a 5 yearly medical. But it is mandatory, and VicRoads aren't really forgiving if you're late with that medical. They will suspend your license temporarily until you've had the medical done. And if you're caught by the police and you haven't got the fact that on your license you've reported that you've got diabetes, because there's a mark on the back of your license that indicates it, then you can have your license suspended until you've reported it and until you've had a medical to get you back on track.
Right.
And hypos, it's an above 5 before you drive too. You're not allowed to drive below 5.
That's right. That's a good message. A quick, I know we're running a bit late, but can you explain a little bit on why should I see a podiatrist if I'm a diabetic?
Well, over time, there's lots of reasons. because a podiatrist will keep an eye on the wellness of your feet. They'll look at your circulation. They'll make sure your toes are right, and they'll cut your toenails and send you off. Take away any calculus, and they'll send you off feeling good. But at the same time, people with long-standing diabetes can have circulatory problems. People with diabetes shouldn't be smoking, but if you have diabetes and you do smoke, your risk of having what we call peripheral vascular complications can be quite high, which is where your circulation in your periphery is compromised. It can lead to poor sensation in your feet because nerves get damaged. So you can walk around with injury, or you can you can have an injury that you don't know about because you can't feel it, or you can have a wound on your foot that doesn't heal very well because the circulation isn't very good. And podiatrists will also help you with finding good footwear. They'll guide you with how to do daily checks on your feet, and they'll also be able to help you with any wounds that occur. They're very incredibly skilled people, podiatrists. From the ankle down, they know everything.
Description. And it's important that people know that almost 80% of foot amputations are because of diabetic complications.
Yeah.
All right. Look. Yeah, we are running a bit late, but I've got a few questions in here. But I think perhaps one that we should try to clarify is that I've been told I have borderline diabetes. So do you want to
well, borderline diabetes? I did talk about a little bit about that earlier. I didn't put the numbers up on the slide because it would have made them very busy. The diagnostic criteria for diagnosing type 2 diabetes, not that you need to do one for type 1, but the diagnosis for type 2 diabetes is either a fasting of 7 or greater on 2 occasions, successive. And if you do that glucose tolerance test, you can either have a random glucose of 11.1 or greater. But if you do the glucose tolerance test and you have that drink, then you need to have a 2-hour post-glucose load of 11.1 or greater. Now, I said at the start of the presentation when I was talking about impaired glucose tolerance that the cutoff point for impaired glucose tolerance is 11. The diagnostic point is 11.1. Now, if you're 11.1, you're not borderline, all right? If you're 11, you sort of are borderline, but you're pre-diabetes. So let's just make sure we get those two things clear. Yes, 11.1 is just 0.1 across the line, but you can't split hairs any finer than that. And the diagnosis is clear. And I know that the diagnosis is hard to hear when you're 11.1 and you're just over the line. But we can't split hairs for your own well-being. And so it's a really important question, I think. A lot of people also call it, mild diabetes and a touch of sugar because you're just across that line. But the message when you use those sort of terminologies is that it's not as important. It doesn't matter. You don't have to worry. And in fact, we want to send a different message. We want to send an opposite message where it is important. It's important to get seen and treat and understand and talk about so that you remain well for the long journey rather than wishing you'd spoken to somebody and had become unwell as a result.
Yeah, I mean that's on that note. It's a good point to finish on. And thank you so much. I hope our audience found this useful. It is always very difficult trying to soften some of the complexes of diabetes, but I think it's important, and it is at the end of the day we're just trying to make it as easy for people with diabetes to address some of the concerns they may have. So on behalf of No Diabetes, thank you so much, and really appreciate your time and your effort to soften these issues. So thank you very much.
Thanks, George. Thanks so much. Thank you.